Hello, and welcome to the DECERA Clinical Education Oncology Podcast. I'm your host, Marie Becker. Today's episode features Dr. Joan Howe from Brigham and Women's Hospital, Boston, Massachusetts, and Dr. Pankit Vachhani from the O'Neill Comprehensive Cancer Center at the University of Alabama, Birmingham, Alabama. They will be discussing the importance of shared decision-making for patients with polycythemia vera or essential thrombocythemia. This episode is part of a larger educational program titled Redefining the Standard in Essential Thrombocythemia and Polycythemia Vera, Advancing Risk Stratification, Diagnostic Precision, and Integration of Emerging Therapies. For more information on our presenters, along with a link to the full educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, my name is Dr. Joan Howe. I am a hematologist at Brigham and Women's Hospital. I am an assistant professor of medicine at Harvard Medical School and also the chief of hematology at Brigham and Women's Faulkner Hospital, and I have an interest in myeloproliferative neoplasms.
Thank you, Dr. Howe. And I'm Pankit Vachhani, a leukemia physician at University of Alabama at Birmingham. I've been here for 8 years. I focus on clinical trials in MPNs and systemic mastocytosis. We have a large MPN patient population over here. That has been my clinical and research interest. Delighted to join you, Dr. Howe. Our topic for today's conversation is shared decision-making in PV and ET, and perhaps MPN in general, but PV and ET especially. So maybe if you can get us started off, Dr. Howe, by telling us a little bit about the process of shared decision-making and maybe share an example from your clinic.
Thanks so much. It's great to be here. I think shared decision-making is important in PV and ET just because there is a lot of gray area in how we treat patients, and it's important to build rapport and have patients feel like they are part of their medical care. So usually for the first meeting with PV and ET patients, I give just a very broad overview. I call it my spiel of what MPNs are and what PV and ET are, and the disease pathophysiology, what complications we are concerned about, and how we sort of mitigate the risks for these complications. And of course, I always tailor it to the level of medical literacy and how much patients want to know, but I do think it's important to give some sort of overview because ultimately this is going to provide context for all my recommendations. And then once I give the overview, that provides a rationale for what I would recommend in terms of diagnostics and treatments. I usually give pros and cons for different treatment options or diagnostic options. If there is a clear option, I'll probably emphasize more what I recommend. And if things are less clear, I am very straightforward about that. And I take into account what patients might value. And a very easy example that comes up often in the first meeting is a diagnostic bone marrow biopsy, for instance. And I think it's important to provide a little context because there is some practice variation on whether or not PV or ET patients get bone marrow biopsies. There's many cases where I'm seeing patients as a second opinion and their first provider, for instance, didn't recommend a bone marrow biopsy. And it's important not to cast that as, oh, that's something wrong that the first provider did. It's just something different, right? And this is the rationale why we would want a bone marrow biopsy, because by WHO classification criteria, it might be required. It's good to have a baseline. It's good to get some prognostic information. But it's also true that very often in ET or PV, a bone marrow biopsy is unlikely to change our recommendations from genetic testing from the blood and clinical features, laboratory features. It's important to acknowledge that and to take into account what a patient might be anxious about, what they're afraid of, what they might tolerate. In patients who are very frail or very elderly, for instance, I often say it's reasonable not to do a bone marrow biopsy right now. Even this relatively early and straightforward decision, it's helpful to sort of provide a little bit more context instead of just saying, oh, we don't need to do a bone marrow biopsy, or oh, we should do a bone marrow biopsy. And I think that also builds trust early on because this is a chronic condition and you're going to have a long relationship with this patient, hopefully. And I think patients want to feel like they're being heard and that they can trust their physician with any decision that comes down the road. So that's sort of one early example, and I'm sure there's many others. Dr. Vachhani, how you approach shared decision-making in your clinic and some examples of that.
I really liked your description of how you do it in the clinic, and you actually touched upon a few benefits. And let me also share some benefits of shared decision making, and then maybe even share an example or two. So much like you, I like to discuss things with my patients rather than just tell them that, hey, this is the diagnosis and this is the treatment that you need. That's not the best way of practicing, because then patients don't know what they have or what their long-term picture is. I think the more educated a patient is about their condition, the better the outcomes. But just to expand a little bit more on some of the benefits, I think first and foremost, it's a better alignment of care where we share the evidence with the patients. They know what the evidence is. They know what to expect out of it then. So in many ways, it helps to calibrate some of their expectations. There's also increased confidence and satisfaction that they have been addressed, not just their disease, but the patients have been addressed in their entirety. And of course, with that comes more satisfaction. As one can imagine, if a patient is more educated and more aware about their condition and their treatments and what the treatments may lead to, both in terms of benefits and side effects, then they may also have a better treatment adherence. Now, to give an example or two, let's say you mentioned this very important point about bone marrow biopsy, and you're quite right. In fact, if you asked some of our other colleagues, many of us may have different opinions on bone marrow biopsies ourselves. The diagnostic criteria suggest doing a bone marrow biopsy, but then for PV, for example, it says you could omit a bone marrow biopsy. And then there's the point of a prognostic value versus an actual treatment decision changing value of doing a bone marrow biopsy. So that was a great example, I thought. But let's take a different example. Let's say in terms of treatment goals. For PV, for example, hematocrit less than 45% is recommended for almost all of our PV patients, unless there's a huge contraindication. But if you go around and ask, there are some patients who say that they have better outcomes or symptom management when the hematocrit is less than 42%, women especially. But it could even be a man who says that maybe their symptoms are better controlled when the hematocrit is less than 42. Then there's also the point about white blood cell counts being controlled to less than 10 or less than 11. There's also the component about platelets. Both in PV and in ET, we don't fully understand where we should be bringing the platelet counts down to. We generally say less than 400 or less than 450, but we don't have a lot of evidence that supports that. So I think sharing this information with the patients and adjusting some of our treatment goals, for example, the hematocrit goal of 42% individualized for a given patient, even though for the vast majority of our patients it may be 45%, I think that is one value that could come out of shared decision making. If we have shared decision making and we know what the goals are, it's much easier to manage. People will stick to it. In diabetes, for example, I don't think anyone will doubt that we should try to bring the hemoglobin A1C around 7% or less. Everyone knows about it now. Patients know about it. Community physician knows about it. Academic physician knows about it. Endocrinologist is also on the same board. I think we should try to get to that same concept even in the management of MPN patients. But just to continue on some of the additional benefits, I think shared decision making decreases anxiety. There's less conflict in terms of, oh, I heard so and so thing from one website versus one physician versus you telling me something different versus some other physician from your own practice told me something different. But I think if the patients know why we are saying what we are saying, it leads to deeper understanding and just, again, less anxiety and conflicts in that regards. Now, why is this so much more important for MPNs? In many ways, shared decision making should be the thing for every condition we treat from A to Z, and we should do that. But in MPNs especially, I think it's very important because we are dealing sometimes with very complex choices. It's not just hydrea versus interferon versus clinical trial versus JAK inhibitor, but then there's also allogeneic stem cell transplant and all of the other pros and cons of all of these different treatment options. And many of these are complex choices. I don't know what choice I would make about some of these if I had to make the choice right this second. So how would our patients make those? So I think sharing again and having a conversation with our patients is important. The second is some of these are very heterogeneous diseases. They may have a shared pathway hyperactivation, the JAK-STAT pathway, but the disease is present in a very heterogeneous fashion. One individual may be very asymptomatic, another one could be very symptomatic. One may not have the white count issues, another one may have it. And therein lies our goal, which is to teach our patients on what their disease is and manage them in a way that they understand and they like it as well. And then, of course, there's also the uncertainty about some of our treatments. Treatments could go really well, but they could also have a lot of potential downsides. And last but not the least, I think it's very important to talk about all the other things that we should be managing for every one of us, including ourselves, which is better nutrition, engaging in physical activities, good optimistic outlook, and to me, I think one of the most important points, which is good sleep. I think we underestimate some of these things. Many of these things, like, for example, physical activity and nutrition, have been even shown to have benefits in MPN patients. If only these could be in the form of a pill, we could have blockbuster drugs. So very important to share these usual things which are applicable for everyone.
I think you bring up really good points, and I think what's often hard and why shared decision making is so important in PV and ET and MPNs in general is that it's very nuanced. It's not like, oh, somebody comes in with cellulitis, well, you treat them with antibiotics, and we're gonna do like a cephalosporin, and if you're allergic, then we're gonna do something else. Like, that's very straightforward. There's an algorithm. Whereas in NPNs and PV and ET, you're right. For instance, with platelets, we don't really know how aggressive we need to be with platelets and what our platelet goal is. And it is helpful to be upfront about it in the beginning, because it might get to a point where if you push a drug too much, they become too anemic. And so then we say, okay, we'll just let your platelets be around 600 or something that's not normal. And then patients can easily get confused because they say, well, I thought that we want our counts to be normal, and now my counts aren't normal anymore. What are you doing? But if you're sort of upfront in the beginning about it to say, well, these are our goals of therapy. Our main goals is to reduce your risk of thrombosis, for instance. And we have the most data for controlling your hematocrit and having a hematocrit of less than 45%. We have less data for platelets. And so we may be less aggressive with platelets just to sort of anticipate common scenarios, and that lessens patient confusion and builds rapport and trust. And again, as you said, adherence. And I think it also has to be individualized to each patient because values are also very different. Even just the decision to start cytoreduction, a patient who's 60 and turns 61 suddenly becomes low risk to high risk. Obviously, we know nothing magical happens on your birthday, and suddenly you're not a different patient where management has to change drastically. And these big transitions can be difficult for patients who may be used to being on observation, and then suddenly we're talking about adding new drugs. And so sort of explaining, again, we're looking at the patient holistically, we're looking at what other cardiovascular risks they may have, and then we look at what they value. I have some patients who are so anxious about their blood counts, and if they see their platelets very high, they message, they analyze their labs day to day. Those patients, we say, even if they're low risk, maybe it would be better if you were on something to lower your blood counts because it's causing you a lot of anxiety, and quality of life is clearly impacted by that. And then some patients are on the other spectrum where they just don't want to be on any medications, right? They want to hold off on any medications possible. They want to maximize any sort of lifestyle treatments and things like that. And so it could be that if a patient is otherwise very, very healthy with no cardiovascular risk factors, and they were on observation and then they turn 61, you don't have to be rigid and say, well, we have to start hydroxyurea, we have to start something because now you're 61 and you're high risk, right? So I think understanding patient values, making sure that they're heard is important. And there's also patients who don't really want to participate in shared decision making. Like, I also have patients that get confused and it makes them anxious to have that burden of making decisions beyond them. And patients say, I will do whatever you recommend, and I trust you. Sometimes for difficult decisions, that can also be stressful for physicians when they feel like all the trust is placed on them and all the burden and any complications then is all on the physicians. There are also patients who don't want to really participate as well. And for very straightforward decisions, you can make that decision, although you should always provide some context because ultimately there's always going to be nuance, especially in this population.
Excellent. Indeed, I very much agree, that this has to be individualized. And like you mentioned, there could also be some barriers at times. Like, for example, there may be some patient literacy issues. As you had mentioned before, some patients may just want the doctor to tell them what to do, and they're very good at doing what has been told to them. I can sympathize and understand that point. I mean, if sometimes we cannot pick a single answer all the time, how would they understand and pick from limited knowledge or limited data that has been shared with them? Nevertheless, I think it's important for us to get together and understand what an individual patient and or family wants to do.
Especially in today's society where now you could just go on ChatGPT and literally say, I have PV, what would you recommend? And ChatGPT would say, would you like a response tailored to your physician that you can bring up? Especially in today's age, there's so many resources. We're going to have a lot more literate patients who are sort of aware of everything that's out there. But at the end of the day, patients do not make good physicians for themselves. It really does need to be a process where we can help explain and interpret the data, the literature, the resources that are out there, keeping in mind patient values, keeping in mind what we know and what's recommended. And I think ultimately, the goal is not just the treatment decision that you're making right now, but the treatment decisions that you're going to be making a year from now, 5 years from now, et cetera. Because this is a chronic condition that can also change. And sometimes it can change, unfortunately, it can change drastically. And so I think building rapport and building trust is very important. And usually this involves making sure that patients feel heard, even things that may seem unrelated to the MPN. It's important that we listen because PV and ET can impact a lot of different aspects of life, feeling tired and feeling anxious and things like that. That can all be influenced by the MPN as well. It is important to have the patients feel valued. So I was wondering, because there's so many resources out there, Dr. Vachhani, do you have any educational resources that you like to provide to your patients to sort of help with shared decision making, or if they have any questions?
Absolutely. We deal with a patient population that is very much engaged with each other and wants to know more about their condition. Frequently, I found that they come in having done their homework before. Like you mentioned, they have used some of these AI tools. They have done some basic work. They've been on some social media and chatted with some patients, and all of that is great. But yes, to your point, I do like to share some resources so that they have information that has been curated, that has been gone through by experts, and things that we approve and agree with. So what I do is I talk with our patients and give my 15-20 minute overview of the condition and the treatment. But beyond that, I do like to point them to a few different educational resources. And I like to bucket these in a few different terms. I'll be honest, I don't always get to talking about all of these in my first visit, but these are some good, valuable resources that one can use in future. So one is the patient advocacy organizations. For example, there's the MPN Research Foundation. They have good patient information kits for those who have just been diagnosed. There's a multimedia program that they have. There's also the LLS, or Leukemia Lymphoma Society, now Blood Cancer United. They have some booklets on PV, ET, MPNs in general, also for other conditions as well. And I like to frequently present that booklet so that patients can see that what they have is what is mentioned in the book, and they can relate to it and realize that they are normal, that they are going through what many others have gone through. But beyond that, there's also MPN Advocacy and Education International. From United Kingdom, there's an MPN Voice organization as well. Not to mention, we both come from NCCN organizations. NCCN is a group of 33 large leading academic centers which get together and form NCCN guidelines. And NCCN has patient guidelines. One could utilize those patient guidelines, and those things are available for free, by the way. So any patient could utilize that. There's also the second term that I would call digital tools and news hub. So what would fall into that? Well, things like PV Reporter, there's MPN Hub, there's Patient Power. These organizations and websites come up with more up-to-date information on PV and ET clinical trials. There are master classes, in-depth articles, there are video interviews with many experts like yourself, for example. Another thing that I like to use is, and I think perhaps even more than me, my pharmacist loves to use, is printing out up-to-date information curated for the patients. Up-to-date has fantastic articles, patient education materials on PV, ET, also different medications. My pharmacist also use some other material that comes out from more pharmacy-related organizations, like, for example, HOPA has some patient education sheets and oral chemotherapy education sheets. These talk about what to expect with different drugs, how to take it, when to take it, what drug-drug interactions there may be in a short form, so maybe in a page or two. And many of these are made in collaboration with NCODA and ONS, which is Oncology Nursing Society. So they also have a lot of information about patient assistance programs. There are some different toolkits available there as well. And then the third term that I would like to talk about is the support and connection that patients can have with each other. Now, obviously, many of our patients have been on social media and they tell me there are fantastic support groups. From what I understand, there's a cancer support community called My Lifeline. There are various Facebook support groups. There's also MPN Net. Now, that's a very long-standing online support group for patients where they interact with each other, share their opinions with each other, from what I understand. But we shouldn't forget some of the other resources. For example, our own nurse navigators, our own nurses, social workers, they too can share a lot of different information and perhaps information that we share, but in a different light with additional angles and knowledge. So important to use our own resources as well. I think something that we could do more, and I could do more as well, is utilize some of our tools, like, for example, symptom assessment tools. These are freely downloadable and usable. Patients could track it. Patients could also have their own journal diary where they jot down their symptoms, side effects, good things that have happened. And one, it's just therapeutic, but two, also it's a good way to keep a log of how things are going, which could then be brought into a physician room at a future visit. And again, that would be of help in shared decision making. And let's also then not forget some of the lifestyle guides. We talked about sleep, nutrition, activity. There's also the importance of skincare in patients with PVED. There are lots of skin malignancies that happen partly from sun exposure, but also partly from some of our medications, which are immunosuppressants. Important to talk about hydration, overall nutrition and movement activities, and also tobacco cessation. Very important to state that because that is a high cardiovascular risk factor for some of the things that we are trying to prevent, thrombosis, for example.
That's great. And I agree that it can be hard to find time to give all these resources, especially because there's a wealth of resources. And just like you, I can do better about providing these resources. I also admit that I tend to only give resources when patients ask me explicitly, just because, especially in the first visit where you're sort of getting to know the patient and introducing the disease and things like that, there's often just not enough time. And I think that is one of the barriers, I think, to shared decision making is there is limited time to really go through everything. And especially in something within NPNs, there's a lot of nuance, there's a lot of unclear data where you just have a lot more to unpack. I think, though, just being conscious, especially in the first visit where there's generally more time for a consultation and you're getting to know somebody, to really take some time to step away from the computer, make eye contact, and really just explain things. I like to write things down as I'm explaining things, and I give it to the patient when they leave. But definitely, we all have packed clinic schedules, and it can be challenging to find time to explain these things and to make patients aware of all the resources that are available. And then other barriers to shared decision making. Obviously, you can see patients who have varying degrees of health literacy, and some patients are very educated, even if they're not in the medical field. They've taken a lot of time to research the MPN field and often come to the visit with sort of a treatment in mind, like they want to do this clinical trial, they want to do this drug specifically. And on the other end, you have patients who have a really hard time understanding, like, what is a mutation, what are red blood cells, what are platelets, what do they do. And sometimes for patients with low health literacy, there might be an instinct to be like, oh, just do this, just do XYZ, right? Because it might be frustrating even to try to explain things. But even patients who have lower health literacy, it's still important to try to give context, because I think patients with lower health literacy, if there is a complication, if there is a side effect or something, they may be at higher risk of stopping their treatments. But if you sort of explain, well, we need to do this in order to reduce the risk of having a stroke, they're more likely to be compliant. But it can definitely be challenging with patients with lower health literacy. It can also be challenging patients who are very health literate, because they might have very strong opinions of what they want to do. And just because they want to do something doesn't mean it's necessarily the right thing. So I think it goes both ways. Also, dealing with family members and caregivers can be challenging, especially there are some cultures where family members take on all the responsibility for their family member. They might not want to divulge information to the family member because they don't want to scare them. And that's very different, I think, from how we approach medicine in Western cultures. And so shared decision making may sometimes seem like it's all with the caregiver. And that can definitely be a challenging situation as well. That's not even specific to MPNs. In general, the bottom line is that shared decision-making is a valuable thing, particularly within MPNs, and it's something that we should all strive for. And it's going to look different for every patient, but I think as long as providers are sort of conscious of the goal, which is to have patients feel like they are heard and that they have a say in their care, I think that's what we should strive for.
Very much agreed, and I couldn't agree more. As important as shared decision making is, there are some barriers. As long as we all work together to overcome the majority of these, I think we would lead to good outcomes for our patients.
So I think we can all agree that shared decision making is very important in taking care of our patients with PV and ET. Dr. Vachhani, any concluding remarks about shared decision making in our patients and all the providers who take care of patients with MPNs and PV and ET?
Sure. Thank you, Dr. Howe. And I think the bulk of our conversation was related to shared decision making between physicians and patients. And yes, that is a very important part of what we do. But also, I just wanted to expand on what shared decision making could be or has the potential to be, which is that it should be a shared decision making with not just the patient and the physician, like let's say you or I, but also with our advanced practice providers, NPs, PAs, also with our pharmacists. And they bring a lot of knowledge to the table. They are very well educated individuals as well. And they can sometimes do things that we can't do so well. With regards to, for example, community physicians, I think they play a very, very crucial role. They are frequently the individuals who manage some of our patients even more than we do. They have perhaps contributed to the original diagnosis in many ways. They see the patients more, they know more about their individual needs or capabilities. Having a line of connection with them where we work together towards the benefit of our patient, pick our treatment options together, and know what the expectations are from some of our medications would be a great thing. With regards to advanced practice providers, I think many of us alternate visits with them. This can only work when our APPs are educated on what to expect in MPN patients. Then only can we have a true shared decision making. To that goal, I would say I frequently put items which are very important for an individual MPN management in my notes, so that the person who is looking at it after me, let's say an NP or a PA, or for that matter, even a nurse or a pharmacist, knows what are the goals for that individual patient and what adverse events have happened or could happen, or what the individual patient is at high risk for things to happen. And to that point, again, pharmacists are very important players in this whole journey. They have information that we don't have. They emphasize information that we don't emphasize so much. And that's actually crucial information on drug-drug interactions, when to take the drug, how to take the drug, how to monitor for these. Many times our pharmacists are checking on patients behind the scenes, even between the visits. So it's important for them to be aware and fully be part of this journey as well. So I think that is all that I wanted to say about shared decision making beyond physicians and patients. But I truly enjoyed this conversation with you, Dr. Howe.
And I as well. And I think that's a great point because MPNs, they touch on so many different aspects of life. And I'm just thinking of all the providers that my patients see. You mentioned advanced practitioners and nurses and pharmacists, but also social workers, nutritionists, physical therapists, all that. And I totally agree. It's a group effort. I want to just echo your sentiment that it's a collaborative effort with a community. And ultimately, I think it really does improve patient outcomes.
Thank you, Dr. Howe and Dr. Vachhani, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Redefining the Standard in Essential Thrombocythemia and Polycythemia Vera, Advancing Risk Stratification, Diagnostic Precision, and Integration of Emerging Therapies, and to claim your credits, please click on the link in the show notes. Be sure to check back soon for a series of upcoming text modules with downloadable slides on diagnosis, risk stratification, and management of PV and ET. As always, thanks for listening.